All right, so you're getting this information from out of your module.
Right.
All right, so you know it's a neurological issue. All right, and even if you go down here where it says fundamentals of nursing care, if you click on these little tabs down here, so in here, it's going to tell you interventions that you should be taking, things that you should be looking at, what kind of findings that you would be looking at for your patient if you were doing, you know, that neurological assessment. Okay. How are you going to do this? What are you going to look at? And also, and this is page 728 in your book. All right. So it's guidelines for nursing care. What kind of interventions would you do? Now, this is a stroke patient, okay? So you want to look at things that correlate with that because everything wants to be, you want everything married together so everything works together and flows together nicely. So as you're going through the scenarios, it's asking you about all this stuff. All right. So box number 1, PMH, that's past medical history. So that should include the patient's history of diabetes, if he has a history of high blood pressure, if he has any surgical history, anything currently going on. Social history, you're going to talk about the patient's religion if it's there. Okay. It might not be there in the scenario, but if it were there, where would you go to find it? Okay, so social history is going to talk about religion, marital status. He's Native American. Okay, so if you think about things that are associated with Native Americans, that would help you fulfill that section. Vital signs. Now you can get your vital signs right in this scenario as you're going through the patient. So you get that right in the vSim, okay? Because the front screen doesn't tell you about his vital signs, but it does tell you about the social history. So it tells you that he smoked for 35 years, 1 pack of cigarettes, well, actually over a pack of cigarettes a day. He doesn't exercise, so he has a sedentary lifestyle, okay? Then it's also telling you about his blood sugar, his diabetes issues. It's talking to you about his left side paralysis, which is going to go in your care plan under your mobility. All right. It's talking about neurologically. Okay. So neurologically, his hand grafts are almost equal, but a little weaker on the left side. So what cranial nerves is this nurse checking on this patient? All right. The pupils are equal and react to light. What cranial nerves would we check if we were checking the pupils? The swallow reflex is intact. What cranial nerve does that correlate with? He's oriented ×3. So that tells you about his mental status. Okay. And it gives you a Morse fall risk assessment score of 60 here. If you don't know what that means, then look up the Morse fall risk because that would help you develop your diagnosis and it'll help you develop some of the other things that you might need for the care plan. Referrals, PT, OT, those kind of things that you're going to need. Okay. It wants you for this scenario to do a vital signs assessment, a neurological assessment, and talk about safety. So all that stuff can be included in your interventions and your plan of care. All right. You're also going to do education on risk and prevention of aspiration. And then you're going to look at the morning meds. Now, if you go back to the care plan, Okay, here's your place for your vital signs, a pain assessment. What kind of allergies does the patient have? And I'm going to show you where to find all that in the patient's chart. Okay, it's asking you about whether the patient takes oxygen. If the patient takes it, you would document, like this patient was on 2 liters per minute via nasal cannula. But if your patient's on room air, you would just put room air. Okay, and what their O2 sat is. So if they're 98% room air, that's what you'll document there. All right, if you're listening to the lungs, and you can do a head to toe assessment, you'll be able to listen to this patient's lungs. You'll be able to document what those lung sounds are. You'll be able to evaluate the patient's skin, the color, the temperature, all that. It's going to tell you if the patient has any wounds or not. Okay, when you do your head to toe assessment, it's also going to tell you if the patient is what their nutritional status is. Is this patient eating or drinking right now? How many people have looked at the patient? Hello, nurses. Miss Siri, to nurses out there, are you there? I got 6 people. I see 6 people. So, has anybody gone into the scenario? No?
Yes.
Yes.
Yeah.
Okay. So when you go into the scenario, what does it say about the patient's nutritional status?
NPO.
NPO. So that's what you're going to put there, right? Because right now the patient's at risk for what? Aspiration, right?
Aspiration.
Okay, because it has that left-sided stroke, that left-sided paralysis. Okay. If the patient's incontinent, if they have an ostomy bag, if you don't know that, then in there you'll put not applicable or unknown. Same thing with continence. Okay. Rest and activity. Now, this is where under gait and all that, you can document about that change in the status and their ability to perform activity. First of all, the patient leads a sedentary lifestyle already. All right. And now, what are you going to want to do with the patient since they had this stroke? You're going to have to get that left side back to try to get that left side back to working, right?
So physical therapy or occupational therapy?
Okay. What else is a problem for this or a concern for that patient if you have left-sided paralysis?
Speech.
Okay. Really, your biggest thing is risk for injury because your patient might not be cognitive of paying closer attention to that side. So if they can't feel that side, they can hit it or injure it and not be aware of it. On top of that, your patient's a diabetic. So now we got a double problem here. Okay. Endocrine. What was the glucose readings for this patient? And
88.
they have any other endocrine issues like thyroid functions or anything like that? Neurologically, okay, now this is where you're going to talk about the patient's level of consciousness. So we just talked about that. It was in your first statement. It told you about the patient's level of consciousness. And as you interact with the patient in the scenario, you can determine what that patient's mood and affect is. So affect means your emotions. How do your emotions correspond with your what you see or what you're presenting? So like if I had an improper or inappropriate affect, I would laugh if you told me that someone just died. All right. Or I should be laughing about something, but I'm crying. So that would be an inappropriate affect. All right. And then over here, it says review of cranial nerves. Okay. Don't put not applicable because I just told you that we went through and we looked at all these different things, right? The swallowing capacity, the eyes, the neurocheck. So we looked at some cranial nerves. What cranial nerves did we look at? How are the patient's other senses? MMSE is mini mental status exam if we didn't do one. All right. I believe there is an option for you to do one there, but if we didn't do one, okay, then it's not applicable. And Glasgow Coma Scale, what would the patient's Glasgow Coma Scale be? Self-concept, okay? Under here, now, if I had a stroke, okay, now I'm a Native American, so what do you know about Native American men? Are they dominant? Are they proud? Or are they pushovers? They don't really care about having control. And what do you think?
I think dominant.
Okay, yes, they're very dominant, right? One man runs the whole tribe. Um, they're very proud, right? They don't want to give up their heritage. When they show you commercials on TV about Native Americans, what do they always show you pictures of the Native American doing?
Their culture, their dance, yeah.
They're crying a lot, always crying on commercials because we've taken their land or we've done something to them, okay, that affects their heritage, their culture. So they're proud, they're dominant. Okay, now I can't feed myself. I'm at risk for aspiration. I'm probably the sole support of the family because my Native American wife doesn't work. She takes care of the teepee and the squaws, and she may even go out and hunt because these women do if they live on the land and they really embrace the land. Okay. How is that going to affect my role or my transition? So this is what the self concept and the role function and the interdependence psychosocial components are talking about. So body image wise, if I'm a proud man and now I can't do things for myself, how's that going to affect my body image? Religion wise, what would you expect me to have? Who do Native Americans seek out as an authority of religion?
The medicine
Medically,
man.
they're going to seek the medicine man, right? That's who they're going to seek medically, and maybe even some truth to that religious wise. And then Erikson stage. What stage at an age is this patient in for Erikson? Okay, I want to know. Role in transition. Okay, so if I can't do for myself, I'm going to have to become dependent upon other people. So we talk about this a little bit through those Setchman's stages of illness. Now, if I'm in a hospital, then I'm already in that stage 3 of illness, Setchman stage of illness, where now I'm transitioning into that dependent role and I have to rely on your treatments. So that makes me feel weak and unimportant and not valued by my family because I can't be the provider now. I can't go out and do the things that I did before. So, how's that going to affect my role? Is it going to put some kind of strain on me? And is it going to put additional strain on my family to now take care of me? And for the caregiver, you might not see as much strain with this dynamic because these women are used to doing this caregiving position. But if it were a woman that were working every day and that's her career, I'm a lawyer every day, it's going to be different for me to have to stay home and now take care of my husband versus someone who is already at home taking care of the husband. But where the role might change is now I may have to not only stay home and take care of my husband and maybe not only hunt food, but I might have to incorporate some of those other roles now that my husband used to do that he will no longer be able to do. And then support systems. So for me, if I'm a Native American, who is my biggest support system going to be?
Family.
The tribe. The tribe, right?
Yeah.
I'm going to depend on the tribe, the chief, and these other Indians under that chief's control, okay, to help provide for me because this is why they're a tribe. They stick together, they help each other. When one can't do, the tribe pitches in and helps. You guys, some of you guys have a system like that in your country where you come from, right?
Yes.
Where you have like a pool of money and you collect that pool of money. And when one family can't do for themselves, you bring that money to them. And then when they're better, they'll collect monies and they'll bring it to you or to someone else when they're in need.
Yep.
So that's your support systems. Also, your family. Yes, he's going to have his wife and maybe his children if he has any as a support. All right, now focal. Okay, what are the focal issues? So for this patient, can you see, do I have the care plan up?
Yeah.
Okay. So for this patient, you see for focal, okay? This patient was in kidney failure, okay? So it wasn't the kidney failure that brought the patient to the hospital, okay? About another hour. Can he just wait? Well, I got to do this, babe. Okay. Always once we got something to do. Okay. Sorry, guys. So focal is what caused me to go to the doctor or the hospital. Okay. If I'm in kidney failure or heart failure, it's not that heart failure or that kidney failure that brings me into the hospital. If I have diabetes, it's not the diabetes that brings me into the hospital. So it's something that happened related to that condition, though. All right. So, like, if I was in kidney failure for this patient, what made him seek treatment was that he felt more fatigued and weaker than he usually feels. His skin was itchier, drier. He was having this decreased concentration. All right. So that's all focal stuff because this is stuff that immediately affects my ability to perform my ADLs now. All right. I can't walk up steps. I can't make love to my wife. I can't cook dinner. I can't go to work because all these things are bothering me. It's not really the kidney failure because I've been in kidney failure for a while. I've been in heart failure for a while. So those things don't bring me to the doctor. But when my shortness of breath gets worse, when I start to feel like I can't breathe and I can't do things for myself, then that brings me to the doctor. So for a patient having a stroke, what kind of focal things would they have felt that would have brought them to seek treatment?
Uh, Not,
Think about
you
it for 1 second. I'm just going to put this on mute real quick. All right, sorry guys, new furniture today, so the other half is a little excited. Okay. All right, so the question that I asked you was about what?
What would have brought him to the hospital?
Okay. So why would these things bring him to the hospital? Because it's interfering with everything that they can do every day, right? If I'm
Right.
fatigued and weak, I can't really just function the way I want to function, right?
Right.
Now, conceptual, when we talk about conceptual stimuli, these are things that contributed to that disease. So if I had a stroke, what kind of things contributed to that stroke?
Hypertension, diabetes,
Okay, the hypertension and the diabetes. What else?
smoking,
My smoking. What else?
Sedentary life.
That sedentary lifestyle. Good. My diet, my cholesterol levels. Okay, anything that could contribute to that stroke or that condition. Okay. Now, residual is things that I may not necessarily be aware that contributes to the disease. Okay. Like maybe I don't have that type of knowledge. Okay. Because I go to the medicine man. So, to the medicine man, as long as I do all these things that my religion and my tribe wants me to be, I'm going to be healthy, right? If I'm not healthy, then it's because I'm cursed by some sort of evil spirit or something. So that can affect my compliance with treatment. It can affect how I eat. It can affect my belief in the knowledge of the disease process. So these are things that could affect me as a person and how um, I can get sicker, but I don't realize that it's affecting me. Also, if I'm in the hospital, this could affect me because maybe my wife, in order to make me make her feel like she's making me better, she wants to feed me, right? Because that's what we want to do. We want to feed people when they're sick. That makes us feel like we're making them better. Even when people are dying, people want to feed them, right?
Right.
So I'm going to try to give my husband what kind of food?
comfort food.
Comfort food. Yeah, not food that he should necessarily have, okay? But food that's going to make him feel better when he eats it. And those foods may contribute further to me being sick. All right, because their cultural foods usually are comfort foods, right? The things that we've had from the time that we were a child, the things that our mothers and our grandmothers and those people cook for us. Those are the foods that bring us the most comfort. So that's your residual. All right, and then we're looking at medications. Okay, so what kind of medications is the patient taking? What's the dose, the frequency, and the route? I'm going to show you where to find that. And what kind of considerations will we give for that? All right, so what kind of nursing indications do we use? One, to either give it, or what are we monitoring for as we're administering it? All right, for labs and diagnostic studies. Again, I'll show you where to get this information. For labs and diagnostic studies, you're going to put what is from the chart and what is abnormal. Okay, this student put everything in here, but really, I just want the abnormals. For this patient, you know, the pH was 7.24, so that's important. The creatinine was 7.14, very important. There was protein in the urine, very important. Okay, so most of the stuff the student put on here was extremely important. Sodium levels, the chest x-ray, the renal ultrasound, what kind of diagnostic testing, what did it show? And then teaching and discharge. Okay, so this should correlate with what's going on with the patient. So if my patient is a stroke patient, they're going to need a referral for some type of physical therapy and occupational therapy. They may need a referral for a nutritionist and for a speech person. okay, because they're going to have to be evaluated. Their diet might have to be changed. So we may have to find ways to meet their nutritional needs, especially if they have an alteration of some sort in the diet. And then what other things? Okay, are there any changes with the medication or how the patient's going to have to take care of himself now because he now has this left-sided paralysis? So, what kind of teaching would you do? What type of referrals would you give? And all that is related to what is correlating, what is directly going on with the patient right now. And really, it correlates to what your nursing diagnosis is as well. Okay, so let's look at our behaviors for a second. So when we talk about subjective stimuli, okay, we're talking about things that the patient can tell you or the patient feels, you can't observe them. So if you look under objective on this one, okay, you see where it says appears to be in mild acute distress. You can't put that for objective. That's not an objective statement. That's wrong because you can't see that someone appears to be in mild acute. That's your opinion and it doesn't belong there. So what would show you that the patient wasn't in distress would be that one, their pulse ox, okay, their heart rate, their blood pressure, vital signs. That's going to tell you, okay, how are they breathing? Are they showing signs and symptoms of panic? Okay, so you have to be able to document certain things. So, like if under subjective, now this patient's talking about his skin is itching, that's good because you can't see that. He's been forgetting a lot, you can't see that. Okay, the periorbital edema, you can put that because you could actually physically see that, and then you can actually describe it. What is it? +1, +2? Is it pitting? Is it non-pitting? Okay, so in there, it has to be something that is measurable. If it's not measurable, it cannot be used as objective criteria. And then where it says stimuli, so for here, you're just going to copy and paste what you put up here in these boxes. Whatever your focal was, whatever your conceptual was, and whatever your residual was, you're just gonna copy and paste that, and it goes right down here
It goes where
it says stimuli, focal, contextual, residual.
Mhm.
Oh, okay.
Okay.
Now look at the nursing diagnoses. Okay, so the priority for this one is excess fluid volume, all right, or fluid volume overload. And why is there fluid volume overload? Okay, because for this patient, the kidneys aren't working. So you have to say that in a manner, okay, so you could put decreased glomerular filtration rate, or you could put compensatory mechanism not functioning, right? Because aren't the kidneys a compensatory mechanism of the body? All right. And then what would show evidence that those kidneys aren't working? Well, we have this edema, the hands and feet. We have this patient's inability to concentrate. We have the periorbital edema. So a lot of things. We have also abnormal kidney labs. The patient's inability to void. So all those things would show, outtake is less than intake. So now I need interventions. And those interventions, since my priority nursing diagnosis for this patient is excess fluid volume, okay, my interventions are going to be correlated with that. So I'm going to weigh the client daily. Why? Because I need to know how much fluid the client is retaining, because fluid retention correlates with weight gain. All right. You don't gain 1 or 2 pounds of fat in a 24-hour period. But if you're retaining fluid, you are going to have a weight gain of 2 to 3 pounds in a 24-hour period. And then you see with this patient, I put the link right there. Now, the link is for the reference. Okay. So if you're going to use a link for your reference like this, it has to go right to that page that shows me that intervention and rationale. Now, why am I monitoring the weight? All right. So I can know if my client is retaining fluid or not. That's my rationale. So I have to have the intervention there that I'm weighing him daily. The reason why is because I'm monitoring for fluid retention. and then my reference. You should have 5 interventions, 5 rationales, 5 references, and they all should correlate with one nursing diagnosis, your priority one, which for this patient, it's the excessive fluid volume. So now I'm assessing and documenting the presence of edema daily to determine the effectiveness of the fluid balance. Okay. I'm going to record and calculate the I&O daily to monitor for fluid retention. I probably would put some sort of fluid restriction on this patient as well. So I might put initiate 1500 ml fluid restriction for patient. Okay. And then I'm going to put my rationale why. All right. Auscultate breath sounds every shift. Okay. I'm doing that to monitor for fluid congestion in the lungs. That's my rationale. Now, what are my goals? Okay. My goals are that I'll report that my patient will report any intake or output to the nurse during hospitalization. That's a short-term goal. Okay. And it's a measurable goal. All right. Can I measure this? I would actually probably write this more like patient will verbalize an understanding of reporting intake or output to the nurse during hospitalization, or within 48 hours, I would say, because that gives me more specific criteria and it gives me measurable now. Now I can go and ask the patient about intake and output to make sure he understands what intake is and what outtake is and what he should be reporting to me as the nurse, because we're going to need to teach the patient to do this when he goes home as well. So that this way, if he's having too much fluid overload, he can right away get a handle on it and not wait until it gets to the point where he has to come to the emergency room. Another criteria, and this is something I can measure. Patient will void at least 720 mLs within the next 24-hour period. Now, if I'm putting that as a goal for the patient, that's a short-term goal. I can measure it. I might want to have an intervention of giving the patient something to make him void. Okay. Now, I can only give him that something if the kidneys can withstand it. So I have to make sure if I want to give this patient something to diurese, okay, like a loop diuretic or something, that it's safe to do that. And it may not be if they're in kidney failure. And that's why we use dialysis, because sometimes the loop diuretics aren't going to work. They're just going to cause the patient to have other complications. Because if the kidneys don't put out, giving them diuretics isn't necessarily going to make them put out, especially if that's not the issue. Okay, and then the patient will verbalize the understanding to report a weight gain of 3 pounds or more in 24 hours or signs of edema to the physician immediately after discharge. So again, that could be a longer term goal because we're asking for it to be done after discharge. So we could say that's a long-term goal. You have to have 2 short-term and 1 long-term goals. Now, my goals, okay, I'm going to evaluate them. So if you look where it says evaluation of patient goal, okay, the patient met the goal of notifying the nurse of any foods and drinks brought in by family and any foods or drinks provided by the hospital. So the patient did this, and now you're establishing a bond with the patient, right? He's telling you about this stuff so that you as the nurse can look at it and make sure if there's any of these foods that need to be included in your intake, that she's aware of it and that she includes those foods. So the patient's meeting that goal there. Patient met goal of avoiding at least 720 mLs of urine in a 24-hour period with the assistance of inserting the Foley catheter to empty the bladder. So the patient wasn't able to urinate on their own, but we were able to get that 720 mLs out. We just had to use the catheter to do it. All right. And then the last one, the patient did not meet the goal. So here you have to have 2 met and 1 unmet goals. Okay, so the patient did not meet the goal of reporting the weight gain of greater than 3 pounds in a 24-hour period or the signs of edema by not calling the physician. All right, so the patient didn't understand that goal and he wasn't able to meet it. Now, as far as your rationales. So, I mean, your references. Some people do it like this. You see with the interventions, they put the little link there after each rationale. All right. I mean, after each intervention and rationale, and other people just put all the references at the bottom, which is fine. Either way you do it. If you're using a book, you're going to put the author and the page number. If you're using a link, the link has to go right to, I should be able to click on that link and go right to that rationale and that intervention. Questions so far? Anybody? Remember, some of you might be on mute.
Yeah. Can you? Let me see.
You should have something in every box, okay? If it's not applicable, then it's not applicable. But if it's not applicable, then I shouldn't be able to find it.
Yeah.
All right, so go ahead.
Yeah, Prof. Lloyd. Where we're talking about the psychosocial honor role function, role and transition. I mean, I didn't. I wrote something, but can you just elaborate a little bit on that?
Role and role transition, okay?
Yeah.
What is your role in the family?
I'm the head of the family and make sure to provide for my family.
Does anybody else in your household work?
Yes.
Okay. So what things do you provide for the family? If you were to get sick and couldn't provide those things, how would that affect your role?
Uh,
The duties that you currently do would now have to be done by someone else in the family, whether it
right.
be your wife, your brother-in-law, your mother, your son, your daughter. Someone else is going to have to pick up that slack, right?
Mm-hmm.
So you're transitioning to a different role now. So now what is your new role?
Maybe my new role would be like maybe playing a secondary role instead of the primary role, where
Right.
I have to go on dependent.
So now you may have to, even if you can, which may not even be feasible, you may have to pick up some of the things your wife was doing at home so she can pick up a bigger burden of the responsibilities you were doing, or so your child can pick up a bigger responsibility. So now you're going from an independent head of the family role to a dependent role. And who's providing that support to you? So for you,
Okay.
okay, it might be your family, your church, your people, some people that maybe you work with, some people that maybe from back home. All right. But for someone who's a Native American living in this country, who is that support system going to be?
His
Right.
tribe.
Right. His tribe, his people.
Okay.
You understand it now?
Yeah. Yeah.
Okay.
That is where.
Anybody else? And if you look at those little, I sent you guys an email, I think it was yesterday or the day before. And it had some stuff on there that you can look at that tells you, that breaks down like the focal, the stimuli, the conceptual, the residual. But if you look at it in here, you should kind of get a concept of what it means.
Can you repeat also the self-concept? The Erikson stage?
So body image, okay? How is my body image affected? Like if I have anorexia, okay? I always envision myself as being what?
Fat.
Fat and ugly.
Yeah.
Okay. If a proud Native American, and now I can't use half of my left body. Okay, how do I envision myself now?
Like useless. I get.
Yeah, useless, weak, vulnerable. Okay. And then Erikson's stage would go by the age, really. What age would this person be at in their life? A 55-year-old Native American. What Erikson stage would they be in?
Uh,
I think I sent you also in there a thing with the breakdown of the Erikson's stages.
so this will be like rural in transition.
Mm-mm.
I'm sorry.
Uh, I guess I said it will be a rural and transition.
I think it's the one right before generativity and stagnation. I'm not
Stagnation.
sure what age that goes up to. It might be the one right before that.
Okay.
All right, so now let's see you go into the vSim, okay? You launch that simulation, go in there. This is Mr. Russell, okay? Again, it's going to tell you that he's a 55-year-old Native American man. And honestly, I bet you if you just Googled, let's make sure it's loaded up all the way. Let's go see this patient. Let me put my computer sound on here. Okay, everybody knows how to get into the vSim?
Yes.
So it does look like it might be generativity versus stagnation. All right. So, in here, okay, this is what you'll first see when you come up, and this is your electronic health record. Now, some stuff will get populated in here as you do it. So as you go through the scenario, it's going to populate. Some stuff is on your first page, and most of this stuff is stuff that we already went through. Okay. If you go into your patient log, okay, that's going to record stuff that you've done for the patient. So nothing will really be there right now. Under diagnostics, there are some diagnostic testing that was already done. So if you go down here, it's going to show you the lab values. Okay. His hemoglobin dropped down a little bit today. So that's abnormal. And remember, I said anything abnormal you want to put in your values. All right. The chloride level is a little bit low. I believe that's 98 to 102. It should be. Well, this one says 101 to 111. Okay. So it already made a liar out of me. And so on and so forth. Okay, so you could just keep going down. There's your prothrombin time. All right, clinical observations. Let's see if there's anything in there. Probably not yet because you haven't really done anything. And then here's your medications that the patient's on. Radiology, if he had any radiology done, it doesn't seem like it. What orders does he have? Okay. So again, this is going to talk about medications and also about things going on. And look at the orders. So, some of those orders, if you look at them, they might be interventions also. How can you use that to your advantage? All right, you're doing these vital signs and neuro checks, so that's going to give you a clue as to what your cranial nerves you'll be assessing, okay? And your vital signs for the top. All right, activity, it's telling you about the patient's activity. It's telling you about the patient's diet. It's telling you about risk factors, all right, and about the labs you're going to order. You might even want to go ahead and do those labs, okay, and see what values come back. And then your eye and nose, okay? So how much did he have in? How much did he have out? All right, then if you close this, then you go into where the patient is. Now, tests and diagnostics are here. So if you want to know your patient's blood glucose, go to test and diagnostics, hit blood sugar.
I'm going to stick your finger to get a drop of blood to measure your blood sugar. You will feel a prick.
Now, you can't do this way to go through the scenario, okay? If you're going through the scenario, you want to start at the top with your safety measures, because if you don't, you're going to fail the scenario for not washing your hands.
94 milligrams
But if you
per
just want to get the
deciliter.
blood sugar, that's how you get it.
We're going to take an X-ray of your chest now. Please try not to move.
Okay.
This will put information in your chart.
The result of the chest X-ray has been entered into the medical record.
So now if I go back to the electronic record, okay? Since your patient had a stroke, now you looked at the chest, we know that, other things aren't there. Diagnostically, it should show us also that we did these. Let's see, I don't know if it will or not, but it shows a blood glucose check and what time. Assessments, okay? Now, neuro is in here. So this is going to test cranial nerves. What cranial nerves is it testing?
I need to assess your eye movement. Please look at my finger.
Okay.
Extraocular movements within normal limits.
So what cranial nerve tests extraocular movements?
I'm checking how your pupils respond to light.
Okay.
The pupils are 4 millimeters and react to light bilaterally. I'm going to perform a neurological examination on you.
Now what nerves is she assessing?
Okay.
How's that tongue? Is that where it should be? And she's
The patient continues to
stressing
have mild
the
left
strength
hemiplegia.
and the sensation.
There is asymmetry when the patient
Okay, so
smiles.
I don't want to see
Puffing
NA there
cheeks
for
and
those.
tongue movement are normal. Gag reflex is intact. His hand grasps are almost equal, but a little weaker on the left side. There is normal sensation in all limbs and the face.
Now, if you want to think about teaching, okay, there's teaching under communication. Under communication, you can also assess for pain. You can assess orientation.
Are you awake?
I'm awake.
What year is it?
It is 2021.
Hey, he already knows that.
Can you tell me where you are?
At the hospital.
Can you tell me today's date?
It is the 2nd.
If you want to know about the past medical history.
Are you allergic to anything?
No, I'm not allergic to anything.
Have you taken your medication?
Not today.
Do you take any medication?
Yes, something for my diabetes and my heart condition.
Are you a smoker? If so, how many packs a day?
Yes, I smoke more than 1 pack a day.
The great thing with this patient is if you leave and go out of the room, you can come back and ask any questions you forgot. Let's say you want to ask about something, but you're not sure where it is.
Do you have any pain?
No, I don't have any pain.
Okay, you could type it in the top. I don't really see much for interventions as far as neuro, but it shows some interventions you could do for this, that, or the other thing you might want to do. Well, for this, the only integumentary interventions is wound care, and this patient doesn't have a wound. See?
I'm going to check your skin for any bruises, rashes, signs of dehydration, or other problems.
Okay.
There is normal elasticity of the skin. His color is normal, and he is not sweating.
So all that's on your care plan. You can answer all that just based off of that, because the answer is going to be the same for everybody that does this scenario.
I would like to assess the ulcer.
I don't think I have an ulcer.
So he doesn't have any wounds. That's why he's saying that, okay?
No, there is no ulcer. Sorry about that.
Again, if you want to measure like his O2 status and all that, you have all that here.
I'm going to press on your fingertip to check the circulation in your fingers.
Okay.
Questions?
The capillary
Yeah,
refill time is
Professor
less
Loesch, how do you go through the step in order to, to do it in a way that you'll be able, to pass, to get a big score? What you were saying, you first got to go and wash your hands, and from there, those steps.
So once you go through the scenario once, look what it does. It tells me everything I should have done. Okay, because for this patient, what are you supposed to be doing? Let's see. Let's go back. You're supposed to be doing a neuro assessment, checking his blood sugar and all that stuff. So when you open up, the first thing you want to do is read this. Okay. And
Okay.
you could either print it out or it's, available to you. You could put it in another screen because it's in the very front of your sim and it's in a couple other places, just so you know what you're supposed to do. But this tells you right off the bat, you have to do a vital sign assessment. You have to perform a neuro assessment and you have to talk about safety. You also have to provide patient education on risk and prevention of aspiration. The morning medications are up and should be administered. So as soon as I go in, the first thing I probably want to do is look at my medications, right? My orders. Your patient got admitted January 1st at 600 hours. He has an order for vital signs and neuro checks every 4 hours. He's supposed to get up and go to a chair, up to the bathroom with assistance. He's MPO by mouth, okay? Speech therapist swallow study, fall risk assessment, CBCs. So here comes the medications here. All right. Now, what time is it? It's 8 a.m. on 1/2/21. So you need to look here and see, what he has ordered for 8 a.m. So most likely it's going to be the metformin, the losartan. So in order to give the meds, the losartan the aspirin's on hold, the metformin, and the chlorothiazide. All right. So he should be having normal saline at 100 mLs an hour, losartan 50 milligrams, metformin 500, and chlorothiazide 25 milligrams. Then you would have to come in first, wash your hands.
I'll wash my hands. Please state your name and date of birth.
My name is Vernon Russell. I was born on January 14th, 1965.
Introduce yourself.
Everything matches. Hi, I'm Gabrielle. I'll be your primary nurse today.
Hi, Gabrielle. Nice to meet you.
Are you allergic to anything?
No, I'm not allergic to anything.
So I know he was supposed to get losartan. Oh, I guess you got to do it like this. $50 milligrams, right?
Mhm.
Yes.
And then you got to compare it with the MAR, okay?
The label matches the medication administration record. The patient can't swallow the medication.
See?
I think the patient is choking.
But see, your patient can't swallow. Now what are you going to
I
do?
think the patient is choking.
You sit him up, I guess.
I think the patient is choking. I am going to assist you into a sitting position. I think the patient is choking. I think the patient is choking.
You're still choking. I don't know what the hell. to do here.
I think the patient is choking.
That ain't the right one. We're not going to give him water.
Maybe respiratory interventions, maybe?
The patient is choking. Can you please take a deep breath? Hold it for a few seconds
think
and
that's
then
gonna
cough
work.
3
Oh,
times
God.
for me, please.
Well,
I think the
obviously,
patient
I
is
haven't done
choking.
this too much. with
Thanks.
the-
This will
with the
help
guy.
clearing your airways.
We would
I think the
encourage him,
patient is choking.
but he's still choking.
I think the patient is choking.
We're not going to give him water. We're not going to do any of these.
I think the patient is choking. I'm going to ask the secondary nurse to come help
that
me
ain't
with repositioning you on your side. I think the patient is choking.
All right, we're going to end it.
I think the patient is
It's gonna
choking.
kill him. We're
The
just gonna
secondary
end it.
nurse will be here. We can go ahead
end
when
it.
needed.
See, now it's going to tell us what we didn't do. All right, so you see how it's green checked the first things we did?
Yes.
Okay, then after we introduced ourselves, we should have assessed the patient's respiratory rate, breathing, and all that stuff. Assessed their pain, and then went into the medication. So you see, if you don't do something, it's going to tell you. It's going to give you direction.
Was there a spot to click like crush medicine? I didn't see that.
Well, let's go back and see. Oh, you know what? It might have been under. You should have assisted the patient to a high sitting position, called a provider to guide you to further treatment, and educated the patient about activities of safety and about risk of aspiration. Okay, so that's what we should have done there. Let's see if it gives us an option with the medications. Here's the thing, like, I don't know about how you're going to deal with the, it only gives you maybe if we had did this.
I'm going to assist you into a high sitting position.
Okay.
The label matches the medication administration record. The patient can't swallow the medication. I think the patient is choking. The patient coughed it up again.
Oh, we saved
I
him on
couldn't
our
swallow
own.
it.
Okay.
So now, I don't know, you probably have to call the physician. It would be my guess.
I'm going to call your provider.
Okay.
I have explained the situation to the provider, and she has entered some new orders in the medical record in order to prevent aspiration.
So now our patient is NPO until a swallow study is performed. So they're not getting anything by mouth.
I have one question, Ms. Loach.
Yes.
So with this SIMS, right? This is the information I'm supposed to use for my care plan, correct? Like when I do
Yes.
this assessment.
Yes.
Okay, so I completed this already. I got 100%. I did a test. Now it gave me like a paragraph thing, like a document thing, like answer some questions. How am I supposed to do that? Just on a WordPad or?
Yeah. So at the end, you don't have to do the DocuCare questions, just the ones that are, let me show you.
Because that's what's confusing me.
Guided
Because I'm
reflection questions you have to do.
okay. Just that.
All
So
right,
skip
so you'll
5.
just download them, answer them, and email them to me.
Okay, so email the answers.
Yep,
Um,
okay, and that's
Wait, the
it. for this-
questions or number, wait, just number, don't do number 5, do number 6.
Right.
Okay. And then you sent like an example care plan. Are we able to use that or we gotta do something else?
The example care plan I sent you is on a renal patient.
Right, but I'm saying, are we able to use that structure? Like, if I was to put my own documents in there, like for my assessment, are we able to use that format?
Oh, yeah, as
Okay,
long
because I
as
was,
it's on the patient with a stroke. Now, I did send you guys, should have also gotten a Word document. You should have gotten, instead of, because the one on the website is a PDF, and with the PDFs, in order to save it, you have to actually hit file and then print and then save as a PDF.
yeah,
And
that's too
once
much.
you save it, you can't go back in and make changes to it. That's the only thing. With the Word doc, you should be able to manipulate it a lot easier.
Right, that's what I've been using. So my care plan is done, but I don't think I'm ready to submit it because like I don't really know. Like I got the labs from my vSims thing in there. I put those labs, but I feel like I'm still missing some stuff because like I feel like I don't have all the information that's on that care plan I have like on the Sims.
Right.
I don't
Well,
know.
go back in it and look over it because none of these boxes should be empty. They should all have something in them.
Okay, so how do you go back into the Sims and get the information without doing the Sims over again?
Oh, you can just go in it. Just open it up and just jump around. It doesn't matter. Once you get a score on it, I don't think it will give you a lower score.
Because I got 100% already. So
Yeah, I don't think it will give you a lower score. I think it gives you your best score in the scenario.
okay. Because I can't see the labs when I went back.
Oh, that you put in your previous scenario?
Yeah.
Yeah,
Yeah.
it's not going to give you the labs. It's not going to recreate your old scenario.
So I would
Every
have to do
time
it
you
again.
open it, it starts a new scenario.
So just I would have to do it again and just write all the stuff down like that, or
Yeah, you would have to go in. If you're just getting the vital signs and stuff, though, you should be able to go in and just get them without going through the whole scenario.
no, I need the labs. But I can't get them because it's on the other screen, like where you can see the orders. Yeah, this screen. So
You should be able to just open it up and go into labs.
okay.
Did you draw additional labs on the patient?
I don't think I had to.
Yeah, if you didn't draw additional labs, then nothing should have changed on that part.
Okay, so I just have to figure that out. Because that's what I'm struggling with, trying to get all these labs back
Your
on.
labs are going to be under diagnostics when you open up the patient's electronic health record.
And can I ask a
Lab-
question? Because
Yes.
on our what's that thing, the syllabi, it was saying that this particular project was due at the end of January, like 20 something.
No, it's due week 8, whenever week 8 is. So I would look in my module. So I asked you guys to turn it in week 7 so I can proofread it and send it back to you before you put it into the module.
Where was this assignment? I'm so confused. This is the first I'm hearing about any of this. So I'm so confused. I'm sorry.
Who am I talking with, please?
This is Heather Marco.
Hi,
So
Heather.
I don't, I'm
So
not,
you have a care plan due,
I'm
and
sorry.
you have a vSim due. The vSim will be doing this week because it's due week 7. So Vernon Russell is the vSim. He is in the point.
So vSim is in the point. Okay, so I won't be directed there. I have to go to the point and find
I'm going to
vSim.
show you.
And will that show up on the modules this week? Or, I mean,
Can
where
you
would,
see the vSim?
Yes.
See my care plan.
I can, right now, nothing. Hold on a second.
All right, this is the vSim, okay? This is in the point. So you go into the point. This is the point. You see it?
Yes.
You see, do you see the main screen in the point?
I see your different textbooks, your different classes.
Okay, so then you go down to L to R,
Right.
hit vSim for nursing,
Okay.
and then go down till you find Vernon Russell and click on him.
Okay. And so, well, will we be prompted to do these sorts of things through the modules, or how would I have known this? That's what I'm confused about.
So your instructor should be discussing this with you guys in class, that and it's also on your calendar. It should be on your course calendar. That your
Okay.
care plan is coming due. Your care plans are due week 8, which is, this is week 7 we're going into now. Your care plan has to be loaded into the module. Now let me pull up the module for you in Canvas.
So on the end of week 8, the care plan will be one of the assignments that will be due.
Correct.
If-
And it has to be loaded up into
if-
Canvas
if-
before it locks on week 8.
But it's not in there now.
It is in there now.
I mean, we can only see week 7 now.
Oh, yeah.
It's
Well, I
not- it's
asked
not
them
in
to
there.
fix, they might have unpublished week 8 because I asked them to fix something on it. Because the way they have the care plan set up, you guys aren't going to be able to put it in there. It's going to look like it's past due because of the way it's set up in there. So I asked them today to fix, yesterday to fix that.
I mean, we have, I don't know if you know this or not, but we have other assignments in there. One's called a packet assignment and some other type of thing, which I don't, like, they're there as assignments, but there's no description of what they are.
Hold on.
But that might not be for L to R, so you can disregard if it's not. I'm not in front of my computer right now. I'm on my phone because I'm at work.
All right, you guys can see my L to R screen.
Yes.
Yes.
Okay, here's your modules. Let me actually go to the student view because no, well, I don't see it there. All right, I'll go back to that. All right, so week 4, okay. Had your blank RAM and care plan, but it had it in a PDF version. So I put it in a Word document version. Do you guys have that?
Yes.
Okay, and then yesterday I sent out some other documents also to your instructor, and hopefully you guys got them. And those documents were a sample care plan, some information on your RAM and how to do it, instructions for the care plan itself, as well as what your focal, what your contextual stimuli and all that stuff is. Okay, so if you don't have it, let me know and I'll send it out directly to you.
Are the RAM and the care plan like one and the same, like they're due at the
Yes.
same time?
The
Okay.
RAM, so in week 4, you should have gotten the template. That's when my students got it. And then your RAM care plan, see here, week 8, it's what it's going to look like. It'll say RAM care plan, submit your plan here. And that's where you're going to submit your care plan. Now, I noticed that some people submitted their care plan where it says case study, and that's wrong. Case study goes where the case study is, not your care plan.
I have a question for the rough. I was going to do my rough draft for the care plan. I want to submit it to them, but I don't know if you wanted it on the email to send it to you. Since
Yes, your rough drafts I want via email. So
Okay.
this way I
Okay.
can show you what you need to fix and send it back to you.
Right.
But regardless of all that, okay, at the end of week 8, you need to put that care plan in. Even if it's wrong, put it in
Okay.
before the module locks. Because
Is-
once the module locks, you can't put it in. Then we can always ask you for revisions, okay? But you need to have your care plan uploaded in by the week 8.
Okay, so can we still submit the rough draft to you?
Yeah, you could still submit the rough draft.
Okay,
Yeah, I would rather you submit the rough draft to me and let me go ahead and correct it.
okay.
because this way you submit the right thing.
Yeah, Prof. Lois, can we go back to the care plan, where, where we have the, I got resident activities, endocrine and neuro. There's something here that I'm seeing, that is not too clear to me. I gotta get this thing done today. And,
Okay, so what don't you understand?
okay, just, honor, fluent, literalize, I see, where it says rates and assessment. I don't know why I need to do that. And for the honor endocrine, where is it, a communal reading? And then to the far right, where it says census and MMSE school.
Okay, we just went over all that.
Oh,
So
maybe I missed.
neurologic function, I just showed you also in the module. What are you going to look for neurologically? You're going to look at what cranial nerves did they assess on the patient. She even talked about the senses. She did a sense assessment on the patient and talked about it. MMSE is mini mental status score. So if you're not doing that on the patient, you're not documenting on that. Glasgow Coma score, if you're not doing that on the patient, you're not documenting on it. Mood and affect, level of consciousness. Affect is the emotions. Does the patient have the appropriate emotions for the situation? What kind of mood is he in? What's his level of consciousness? You can do all that through those questions I just showed you.
Okay.
What
I'm
else?
sorry, not to sound redundant, but just so I understand, the RAM and the care plan, this is a RAM care plan right here. It's just one thing, right?
Yes.
Okay, thank you.
Did you guys from the day class get the documents that I sent you? Or are you
I think-
checking your emails for the
Got
documents that I'm sending?
Today.
Yeah, I think I did.
We just
Okay.
got, yeah, we got them today.
Okay.
Yeah, today.
So, each one of these boxes has to be documented in. If they don't have an IV, put none.
Okay.
All right. There's no wound, so you can put none. He doesn't have a drain because he doesn't have a wound. But it told you about the color of the skin. It told you about the temperature of the skin. It told you about the turgor of the skin. So those you would document. It told you about the patient's allergies. The patient's NPO. So it told you about the nutrition. It didn't tell you what cranial nerves were assessed, but you should know by the assessments that were done. And if you don't, then you got to look it up. Okay, again, self-concept is what kind of body image is this Native American who can now not do things for himself, who now has to be dependent on others. How's that going to affect his body image? What would be the typical religion of a Native American person? And what would be Erikson's stage for a 55-year-old? If he went from being a proud, dominant male that took care of the family, and now he's dependent upon everyone, the tribe, the wife, how's that going to affect his role? Who's his support system? Is it the tribe? Is it the church? Is it his family? Is it the community? Is it all of the above? Focal, what brings me to the doctor right now? What brought me today? What would be the focal signs that you would have expected to see for that patient with that stroke? And it talks about what happened to the patient, so make sure it is in line with that. The stimuli, conceptual, what caused that stroke to happen? A combination of things: diabetes, hypertension, non-compliance, diet, Elevated cholesterol levels. What are the residual effects? So how does his culture, how does his religion, how does his developmental age, his knowledge of the disease, how does that all affect his ability to be compliant, or make him sicker, or affect his ability to handle and cope? What are those residual things that would play a part? Medications. What medications is he on? What's the frequency? What's the dose? And what do we have to consider for those medications? Also, what's going to be the difference now if we can't crush those medications because the patient can't take anything by mouth? Are we going to have to consider making changes? What labs and diagnostic testing was abnormal? Now that our patient has become dependent upon us, what type of new things do we have to teach them now that they're at risk for aspiration, now that they're at risk for injury due to that left side paralysis, they're at risk for additional strokes? What kind of referrals are they going to need? They're going to need nutritional referrals. They're going to need probably referrals for people that specialize in cardiac or neuro. What are the subjective signs, things that the patient's telling you about themselves? I feel dizzy. I feel itchy. I'm nauseous. What are the objective signs? The patient is pale. The patient has +1 pitting edema. The patient has a blood pressure of 200/110. The patient has a heart rate of 148. It has to be measurable. In the stimuli, the functional, contextual, residual, whatever you put in the boxes above comes right down here. Nursing diagnosis. It can't have a medical diagnosis in it. Okay, so what is my major problem? You have to have 3 nursing diagnoses. Which one is priority? For this patient, it is excessive fluid volume. What's causing that excessive fluid volume? The poor glomerular filtration rate, or the compensatory mechanism, is failing. What is our compensatory mechanism? The kidney, but you can't say kidney, but you can say the compensatory mechanism is failing. And how do we know it's failing? Well, we have fluid volume overload as evidenced by edema of the feet and hands, the lack of the ability to concentrate. We're not voiding, those kind of things. What kind of interventions would I do for this patient? The interventions want to be correlated or catered to the nursing diagnosis. So if I have fluid volume overload, then I have to do interventions to either prevent that or to decrease it. Okay, so to prevent it, I can decrease the amount of fluids that I'm giving my patient. I can monitor it by weighing my patient daily. I can monitor it by measuring how much the patient's taking in versus how much they're putting out. There might be medications I can give the patient, or maybe I have to do other interventions. So what am I going to do for this patient to address this fluid volume overload? That's what my intervention should be. And my rationale is, why am I doing that intervention? So why am I monitoring the patient's daily weight? Well, it's going to tell me if the patient has excessive fluid retention. Why am I restricting fluids? Okay, because my patient's already in fluid volume overload, so I don't want to make it worse. Why am I recording the I and O's? Because I want to see if I have a negative retention rate. Is my patient holding more in than what they're putting out? Or is the intake exceeding what the output is? Because they should be close to being the same. Why would I listen to breath sounds on this patient? Because I want to know if there's congestion in the lungs, because I'm going to have to address that, because it's going to affect my patient's ability to breathe. What are my goals? My goals are going to be things that I can teach the patient to do at home to correct the fluid volume overload. So what kind of things could I teach this patient at home to do? I can teach the patient how to count the amount of mLs in the fluids that they drink. I can teach my patient how to adhere to a restricted fluid schedule. I could teach my patient how to weigh themselves daily. Okay. I could teach my patient when they're having difficulty breathing because of this fluid volume overload, how to sit up in bed or how to, elevate themselves at night using pillows so that they can breathe better. Maybe I can teach my patient about, dialysis or how to catheterize themselves if they need to do some sort of elimination. So what can I do? And the things have to be specific and measurable. So patient would be able to verbalize, okay, the amount of intake and output to the nurse, let's say within the first 24 hours of admission. Okay, because now I have something clear and specific that I can ask the patient about and I can measure the time on it. So it gives me specific criteria. The patient will void at least 720 mLs within the next 24 hours. So that's clear cut and to the point. It's a great short-term goal. Okay, you need 2 short-term goals, 1 long-term goal. So this patient's long-term goal is they'll be able to verbalize an understanding of reporting a weight gain of 3 pounds or greater in a 24-hour period, as well as signs of edema to the physician after discharge. So after discharge makes it a long-term goal. All right. And they're being able to verbalize about this weight gain means they understand when they have excessive weight gain that it's fluid and that they need to notify their physician, because if not, their body's going to continue to deteriorate. And now evaluation is evaluating those goals. So now I'm going back and I'm evaluating those goals. Was the goal met or not met? You have to have 2 goals met, 1 goal not met. So the patient met the first goal by being able to notify the nurse of whatever foods and drinks were brought in by the family so that the nurse can include those in the I&O. All right. So that was a big goal for the patient. If they're a person that's non-compliant, that could be a pretty big goal for them. And they have to do it within that period, a time frame. So if they were supposed to meet this goal within 24 hours, then they have to meet it within 24 hours. If they don't do it within 24 hours, then the goal is not met or partially met, which means we go back and evaluate and we adjust so that we can get the patient to meet the goal. Patient met the goal of avoiding at least 720 mLs of urine in a 24-hour period. They had to use a Foley catheter to do this, but they were able to get that much out. Patient did not meet the goal of reporting the weight gain. So this goal the patient wasn't able to meet. So you have to have 2 met, 1 unmet. For interventions and rationales, 5 nursing interventions, all towards your priority nursing diagnosis. Okay, the other 2 nursing diagnoses are there, but you're not catering anything towards those. Those are just additional nursing diagnoses that this patient might have. Each one of these interventions and rationales has a link to it, and that is a reference link. Now, these reference links wouldn't be good enough, okay, because they're not going to take me specifically to that intervention and rationale. So I need a link that's either going to take me right to the intervention and the rationale, or I need an author, a book, and a page number. And you can put the rationales, the references right there like they are in this one, or you can put them down at the bottom. Questions?
What was it again for the book? You need it.
The author,
Mhm.
the name of the book, and the page number.
Thank you.
And you guys, I sent you guys the NANDA nursing diagnoses and all that stuff. That should help you do this, along with resources of pages where you can look up some of this information. Okay, any other questions?
Lodge, the patient's initial code and code status. Didn't see that.
The initial code is just the patient's name, their initials.
Okay.
The code status, if it doesn't say DNR, DNI, DNH, then the patient's a full code.
Okay.
Okay.
And PSH is social history, not surgical history. I know usually you guys are used to putting surgical history, but because it's RAM, and everything's about behaviors and the way we accommodate our behaviors in response to what is happening in the body. It's social history here.
Miss Lodge,
Yes.
is there any way we can access this after the lecture that you recorded? You can YouTube or any site that we can retrieve it?
Yes. So if you subscribe to my channel, you should be able to see it. And usually I share the links, which I will share the links today. But once I actually stop recording, I have to wait for the videos to convert. And I'm going to be stepping out for a minute. So depending on what time I get back tonight, if they're converted or not, then I can go ahead and send you the links as soon as they're converted. So you might not get the links till tomorrow.
Okay, thank you.
Mm-hmm. Other questions? And I have other videos already up there. If you have the link to my video site, you should be able to go. Are you guys, when you guys go into my YouTube channel, are you able to access the other videos that are there?
Yes, I was able to access one that you sent through Outlook, but when I searched for your name on YouTube, I couldn't find the one that you sent through your email. It was like a different videos.
Yeah, because they're not, most of my YouTube videos are not published to the public because of uh, copyright.
Oh, okay. So should I always access from Outlook or I should?
Well, once you assess it, who can share their screen with me that can access one of my video links? Are you able to?
Hold on for me.
Because I want to see something once you go in there, if you're able to access the other videos.
Okay.
And I mean, I have other videos on there about doing care plans. This one might be a little more clear just because I really was a lot more prepared for this one. And I felt like I went more straight through with this one than I have with the other ones. So.
Trying to make this.
Do you know how to share your screen?
Yes, I do.
So go ahead and share your desktop with me, and then I can kind of guide you through the rest.
Okay. I just did.
Okay, so open up your email.
Outlook.
Yep, you should have a video link in there from me.
Okay.
Type in care plan in the top, because I think I sent you guys a link, a couple, or put YouTube links, actually. Put YouTube links. Yeah, click on that one. See, if you hit the second link there, that gives you the subscription to my channel.
Okay, I'm gonna go back. Is it the second one? This one?
Yeah. So if you click videos, it should show you all my videos.
Okay. Yeah.
Now, if you scroll down, you see some chapters that you guys have up. I already have recorded, by the way.
What? Oh my.
Now, if you scroll down, all these, not all these are for L to R, but most of them are. If you scroll down on the side with the bar, you should see one there that says care plans, but I don't see it.
Yeah.
Type it, you could type, I don't know if that's going to search my channel though. That might search all of YouTube.
What am I
Try
doing?
this search down here where it says about.
Okay.
Next to it, there's a search icon.
Oh, that's why I have
This search icon here. See, no, not that one. The one that's next to about.
Yeah, I can't see because of the screen for the Zoom. I'm
And
trying
maybe you have to hit subscribe to see all my videos. I'm not sure. On here, on the right here on your screen. Go backwards.
What is this?
You clicked the wrong one. Go backwards. See where it says subscribe on the red tab on the right? No, not there. On the right. Yes.
Yeah, I can't get it because of the Zoom. I'm trying to move it from that side.
Let me see. your remote.
I think there's a video running. There's a video. I'm trying to.
Well, the video that's running is here. So if you hit that X, that should close it out.
Let me close this up. Close this up.
The YouTube L to R.
Okay. Because I couldn't figure where the video was coming from. Oh, I can't get to that side to click on the subscribe.
I'm asking you for your remote.
Okay.
You have to sign in to subscribe. I don't know if you have a YouTube channel, but you got to sign in to subscribe.
Okay.
Once you subscribe to the channel, then you should be able to see all my videos. Okay.
Okay.
So, excuse me, Mrs. Loesch, should I assume that you teach another class? Is that why I'm a little bit lost?
I teach L to R.
Okay.
But I also teach a ton. I mean, I tutor, not teach. I'm the program chair for evenings for the RN program.
Okay. I'm just trying to understand because you have information that I didn't hear before and things like that. So probably because I have a different instructor, correct?
Yes, you're with Miss McKelvey, right?
Yes. All right. Thank you. Sorry, I was confused.
Has she been talking to you guys about the care plan?
Not so much. We were very focused on midterms and we haven't met again since. So probably this week, I guess she'll be, delving into that.
Yeah, I thought she was going to jump in with us today because she asked me about the session, but I didn't see her jump on. So,
okay. So that's all right.
But I send you guys the same links and all because your care plan is the same as ours. It's all due. It's all the same patient. It's all due. But I'm very proactive because my thing is I want you guys not to get bundled up at the end with a bunch of stuff that you have to do. So I try to keep it the focus from the day one for this stuff.
Okay. I appreciate that. So the other thing is if I do submit a rough draft, I said that to Ms. McKelvey, not you, correct?
Correct.
All right. Thank you.
All right. Anybody else have questions? All right, then we're good here today. I'm going to end the session because I got to go do a couple things today, but it's already recorded. So as soon as it converts, I will send you guys out the link. If you have questions, even if you're in the day class, you can send them to me and I'll try to help you.
Okay.
Okay,
Thank you.
bro. Thank you very much.
All right, you guys have a great Saturday. I'll see you. Everything's back on starting Monday again. I hope y'all enjoyed that little bit of time off and you had a happy new year.
Thank you.
All right. Good to see you.